Nicole. I'm an orthopaedic surgeon based in Cairns in far north Queensland, and tonight it is my great pleasure to invite back Thriving Lives to talk to us more about pain. I would love to hear more from Jordan Bonner, and I hope you enjoy it. Thank you, Jordan.
No, thank you. Thank you very much for having me. I guess as Dr. Cole said, I'm Jordan. I'm the Principal Physiotherapist from Thriving Lives Co, and I am here tonight to talk about a topic that I'm very passionate about, which is interdisciplinary pain care. Now, I would like to start by acknowledging the traditional owners of this country and the Yidinji land on which we meet tonight. I pay my respects to their cultures, their resilience, their strength, and to elders both past, present, and emerging. Now, again, I work for Thriving Lives Co. I used to work for FNQ Chronic Pain and Disease Rehabilitation. We have rebranded TLC. Thriving Lives Co. is much easier to roll off the tongue.
Yeah.
But I guess as the name previously said, like FNQ Chronic Pain, it's always very much been an area of special interest, I guess, for David, and then, as the team has grown, the wider team. I guess, so why are we passionate about pain? Chronic pain affects approximately 20% of the world's population. Chronic pain causes the highest number of years lived with disability when compared to all other illnesses and disability. And chronic pain is the largest cause of work-related disability. So when you take all of that into account, we have a lot in the medical allied health profession that we can actually do to help the people that are experiencing chronic pain. It's a big problem. There's a lot that we can do, a lot that we can help with. So a little bit about me to be moderately self-indulgent. I grew up in God's country, grew up in Townsville. I know you can't hold that against me. Everyone continues to tell me when I tell them that, I've gone on to better pastures, and can't disagree, but it's been a great move. Much like every physiotherapist that I think I've ever met, something of a washed up athlete. Used to play pretty moderately okay quality like cricket, hockey, cross-country running, where I did a load of injuries, ankle, knee, busted my shoulder, had a recon, spent loads of time on the physio table, and it's very much where I then got my passion for physio. I did my 4 years at JCU, graduated in 2014. From there, I went straight into musculoskeletal private practice. To begin with, it was very much like, Townsville, it's a garrison city, so a lot of veterans. So immediately that comes with quite a large persistent pain population, let alone, some of the clinics that I worked in received a lot of referrals in, the third-party CTP work cover space, where again, you're dealing with a lot of different yellow flags to do with pain, which again, I really enjoyed doing in the first few years. So I guess that sort of really took me to a point where in 2018, I actually sort of jumped ship from general and started working in a private pain clinic in Townsville. Moved to Cairns in October of 2022, and I guess this year I actually completed a professional certificate in pain science through the University of South Australia. Thank you. I guess, similar probably to yourselves, as a physio, you hang out with other physios, you hang out with other allied health people, so you go to barbecues. Yeah, that's what we get when we're friends in the room. I'm glad that was on recording. But, you go to barbecues, for example, you have a general conversation, how's work? When I talk to people about pain, I guess the response that I tend to get is, I don't know how you do it. A lot of people are like, I'm a curious cat, I try to sort of, needle a little bit. Why do you think like that? The general response is very much, not enough time, not enough energy. As far as, working with pain, especially when, say you're working in a clinic that doesn't allow for enough time to actually sink your teeth into the multifaceted nature of pain, it is exhausting because you're constantly going to feel like you're chasing your tail. Which I guess for me makes it then very easy because I love pain. And when we have these sorts of conversations and they'll say, I'm just going to send my patients to you. I'm like, yes, please. But you know, it is an area that you sort of have to love. And yeah, I'm very glad for that reason that I work where I do. Now, I guess when we look at it from the perspective of, you know, looking back on, say, my new grad years, what my friends actually say at these barbecues does make a little bit of sense, you know. When you understand, I guess, what you had experience in, and if you haven't had experience in it, it's really challenging. And it's, I guess, when I look back about how I felt as a new grad, I'm glad to know that the research literature actually supports that. So, I'll just flick across, I think. So, Forbes and Ingram in 2021 actually did a qualitative study where they went to a university and they wanted new graduates to do a semi-structured interview on how ready they felt to treat people with persistent pain following their tertiary studies.
It's not going to be good, is it?
No, look, it's not horrible, but I guess what they then found is when they did their analysis was, that there were very much 4 sort of evident themes. So, the reality of complex nature of chronic pain. I guess something that they identified was that at uni you get taught this is what will happen, but then in life that's not actually how it happens. So they suggested that, you know, long-term management was not a focus of their university training. You were sort of taught, here's the biopsychosocial model, here's what you're looking for, here's the flags, there you go, you can treat chronic pain, rather than actually, you know, how to implement that into practice. So again, the themes were very much that the students suggested, you know, that as far as proper experience is going to increase your confidence by just having that practical hands-on learning. Like one of the direct quotes from the students was, you know, there's not much that can substitute seeing a large volume of different people from different backgrounds and learning to convey your message to all these different people. Everyone learns differently, everyone listens differently. And so if you try to apply, you know, a cookie cutter approach, or, you know, trying to put, you know, a square through a circle and all those sorts of lovely analogies, like if you're trying to apply the same thing to every person, it's not going to work. And that's very much something that in this qualitative study that they identified one of those themes. The next theme was how to actually negotiate management with a patient. Everyone typically comes in to see a physio, you know, and they have a degree of expectation of what they're going to leave with. The thing with pain is that, especially when it comes to persistent pain, people expect a quick fix. They expect, I'm going to walk in, I'm going to see the physio, I'm going to see the OT, I'm going to see whoever, then I'm going to walk out and I'm going to feel amazing from this pain that I've had 15 years. It's like, that's maybe not realistic. So again, the theme in regards to new graduate readiness was how to manage those differences of opinion, how to manage and address unhelpful beliefs. Because again, if someone comes in, say to use knee osteoarthritis, I have to stop walking because knee OA is going to, it's going to get worse by me walking. Trying to challenge those beliefs and actually pick and choose, how do I do that? When do I do that? Have I built enough rapport to actually be a little bit combative with someone, rather than, I guess, letting it go and actually potentially contributing to the belief by not correcting them. It's very much art versus science in that regard. So again, you can only imagine as a new grad, let alone I still find sometimes it being challenging, let alone remembering what it was like sort of 10 years ago. So again, the last thing being a challenge how to actually promote engagement in self-management. It's all good and well to give people the tool, but you've got to sort of motivate them enough to actually believe in what you're saying so that they go and do it for themselves. Again, to quote, they've been using passive strategies for most of their management. Being the physio that turns around and says you've got to do this or you've got to do that is really quite hard. Next, I guess similar to the first point, but the role of direct experience. So I don't know, again, as far as the other degrees in the room, but say for myself at uni, it is pretty similar with this here. So the suggestion that direct and authentic practice in managing patients with chronic pain led to increased readiness and confidence. So at uni for ourselves, the OSCEs or your practice exam, you walk in, 9 times out of 10, it's either one of your mates who's pretending to be a patient in chronic pain, or it's a uni lecturer. And what they want to hear is they want you to say the buzzwords, biopsychosocial, and ask this question and ask that, and they go, yep, tick, you passed your practice exam and move on. As compared to working with like a real person with real emotions who very much like, well, I'm going to say biopsychosocial. Well, I've heard psycho, you think it's all in my head. Well, no, that's not what I'm saying. Like, so again, you're not working with real people in those examples. So again, as far as going out into the real world and dealing with that for the first time can feel really daunting. So again, there's a difference between theoretical management and practical delivery. Again, as I sort of said before, even with practical delivery, of having different ways of saying it, because you actually start saying to someone, well, that's actually not sticking, I've got to do a different way rather than, no, this is how I do it, and say good luck. The fourth, I guess, and final part is, I guess, given that the study was happening like after graduation and you're starting to work in the field, the last theme of, I guess, asking about new graduate readiness was they identified that like workplace systems and ongoing further training are super duper helpful. So, having those who worked in like a supportive organisation that did have, say like clinical roundtables where you talk about a topic, like regular scheduled case conferences, scheduled one-on-one supervision sessions where you can say, hey, David, I've got this troubling client, can you help me? Not having those sort of, I guess, like strategies in place definitely, hurt some of that fostering of your ability, whereas, again, when they're in place, it makes things so much easier. And these really clever new grads, which I'm so glad to actually have read, was that an interprofessional team is valuable when managing those with persistent or chronic pain. Given that, if you have somebody who maybe does have, say like some mental health flags, just for argument's sake, you do have a psychologist that you can maybe go and bump ideas off or get, it's almost, I know we're here talking about interdisciplinary, but almost getting some of that transdisciplinary, I guess, help on how do I get through them or how do I help them manage this situation for themselves. Having other people that you can bounce ideas and, it's just doing nothing but helping build your own wide set of skills to help deal with persistent pain clients. So, given that was in regards to new grads, thinking back to talking around the barbecue, and like for the purpose of the drill, let's just call it Josh, which again that was his actual name. So I hope he said he was watching tonight. We'll see. But we're no longer new grads, so it sort of got you thinking, well, how come I still go to events and people say the same thing, yet we're not in like our first 12 months. So Penlington et al. Completed a study, admittedly based in the UK, but they took 258 experienced health practitioners, and you can sort of see the breakdown here. We had GPs, pharmacists, nurses, physiotherapists, social prescriber. Admittedly, I have to look that up, but in the UK, my understanding is that it's essentially like a nurse practitioner who can then make referrals. With my understanding, if anyone corrects me, please feel free to do so. Health and wellbeing coaches, and then others. So others was OT, social work, psychology, care coordinators, and then like non-specified health practitioners. So yeah, 258. So when they broke down those 258 people and asking in a survey form, scale of 0 to 10, what is your confidence in being able to assist someone in self-managing persistent pain? They then asked, and 22%, 56 people, had identified that they had previous training in persistent pain, but there was no statistical difference in their confidence in supporting people. Then when they, again, continued to break it down, these are just inverted because, again, I was struggling to wrap my head around it, but 86 respondents reported having no previous training to support self-management. So again, suggesting that, 67% said that they did. So you can sort of comfortably say that if I'm a physio, I've had training in self-management. But I guess what's the sort of the concerning thing here is that when you actually break down the confidence, just remembering that 67% of people said they had training in how to self-manage people. 22% said that they had training in pain. Like the majority of people were below a 5 out of 10 as to whether or not they had the confidence to help someone. So there's very much, again, like when we, like, it just reinforces what we're sort of saying about new grads, you know, like it's all good and well to have had training and exposure, but it's another thing to actually have had the experience to then have the confidence to do it. Which, again, sort of indicates that our big problem is getting even bigger. Thank you. I needed it. Alright. So like, I'm not going to sit here and pretend, you know, that there aren't challenges to working in the persistent healthcare space. So, Polachek et al. They completed a study where they identified, I won't go backwards because it was sort of wigging out when I was practicing, where they had 16 health practitioners who are like self-identified as having interest and or experience in working with persistent pain across the US, and then they completed a 60-minute phone interview, and again the themes were analysed. So with the 4 themes that they found was that there was a system level of theme where finding that within your own organisation, having like limited and inconsistent processes of how do we support people with pain is just so, you know, it's ineffective. And I guess especially in the medical space, the next comment is that not necessarily being able to like track care trajectory of not having enough return communication, or you know, you have someone, I'm going to refer you off in this direction, not hearing back from them, they come back months later and you find out that, oh no, it actually hasn't been helpful, you've been off doing your own thing and not having any luck. And even between then, I guess, who you're referring to, like inconsistent management approaches, where again, especially like in the, like we'll talk about it a little bit more in a moment, but like the multidisciplinary as compared to the interdisciplinary. If you refer to 3 or 4 different practitioners, you potentially have a biomedical belief system, a biopsychosocial belief system that are conflicting information. Again, it's super challenging then to actually like monitor how the patient is going. And again, that sort of links in, I guess, with that sort of transition of care, you know, like it being more fragmented and less, I guess, like more variable, I guess. So let's see, there we go. So again, when talking to the doctors from a pain management perspective, the suggestion is that from there being, you know, like an opioid epidemic and there being, I guess, even by a clinic, or clinic by clinic, you know, we do not prescribe opioids, or we do or we don't, and having restrictions that sort of made the doctors feel like more of a drug gatekeeper rather than like a partner in your pain, and actually feeling then, you know, that they weren't really able to contribute appropriately to someone's management, you know, part of the team. It was like, well, you've come for medication, and I'm saying no, all right, see you later, good luck. It is really challenging. Another challenge that they said from a resource perspective was having access to a local pain clinic or an accessible pain clinic was, again, another challenge that they sort of found. The third layer was, I guess, from a provider, like intrinsically themselves. The suggestion was, again, that having short consultation times didn't actually give the providers enough time to what they felt was to get down to the nitty-gritty of the root causes of the biopsychosocial model. They all understood biopsychosocial is where it needs to be at, but we potentially have, you know, 7 minutes, 14 minutes to sit, talk to someone, get them out to the next patient, and how are you going to do a deep dive, and then run late for the rest of the day. You know, it 100% makes sense. I guess similar to what David was saying last time, but you know, as far as from even within like referrers themselves, you know, the variation of I do it one way, I do it another, and you know, at times we make a limited guideline adherence or not having a standardized approach. Okay, we have someone with persistent pain, how are we going to manage it? It becomes, again, challenging. And you know, similar again to from what we were talking about with the new grads, lack of education. If we don't have, you know, like up-to-date literature or up-to-date learning that's occurring, it makes it, again, super challenging when you've got someone in front of you who says, I've been in pain for 15 years and what do I do about it? The last one, I guess, in the provider was the lack of communication received. So again, it's all good and well, say if Dr. Cole, you write a letter off to Jordan, the physio, if I don't write something back to give some sort of suggestion as to how it is they're actually going, naturally, that is going to make things incredibly hard when the patient is next sitting in front of you. For you to actually say, well, what have you been doing? What's going on? Has it helped? Has it not? Without having all of that up-to-date information.
Health record.
Yep. Yeah.
Do you think you need it?
Oh, look, I would suggest so, but again, it's for much bigger fish to fry, I guess, than myself.
It would help you. You could read my GP letter every time.
It would. Like, to be frank, from, we, like, I guess, and this is where for us as an interdisciplinary clinic, and I'll talk about it more later, but like for us having access to all of our own records, like it's so helpful because I can walk next door and talk to David, but I can also read his notes.
Yes.
And like the amount that I can glean from just reading the last clinical note to then be able to pick up where he left off, or and no, I can talk about it now, but or the patient not having to repeat themselves is worth its weight in gold. So, in that space, like any letters that say back to the GP and are CC to Jordan or vice versa, like if I write a letter, I do try to get out of the patient, hey, who should this also be going to? And try and CC basically as many people as I can to make sure that these sorts of things aren't being or not contributing to the problem. So that's the third point.
Just to add to that, I sometimes will ask if I got correspondence new Dr. Cole, I'll ask them, what did Dr. Cole tell you, to see what they understood?
Yes.
And it's just sometimes they'll say, oh, I haven't really done much in my session. They're just moving my hand around and that's it.
Exactly. And to sort of also add to that as well, chronic pain is very much like linked to cognitive changes. So, when you have someone who's been in pain for, I guess, even as soon as 6 months, 8 months, and then they're showing memory loss changes, and it's very much, it's challenging because how much of it is true, how much of it is memory loss associated with I'm not sleeping well and having, brain changes. So it 100%, like just that clear communication to eliminate ambiguity is super helpful.
Just to know what they've understood.
Exactly.
Well, then if we have the correspondence and you can rehash it and be like, oh, actually, this is what I've been told.
So the last point from this particular study was patient. So again, pain is complex, it's unique, it's individual to the person. If everyone is on a different point of view in the continuum of I've just hurt myself to I'm recovered. And I guess depending on where you're at, I guess going back to like the cookie cutter model, like if I just apply the same treatment approach to everyone, they're not necessarily going to get great quality care. So though the quality of care and like just that different point on the continuum really sort of go hand in hand. I guess next point in regards to patient being that perception of pain and therapeutic expectations, as we sort of alluded to before in the new grad discussion, is that people might come in, I've been in pain for 20 years, they describe this enormous amount of, say psychosocial contributors to a pain presentation. They really want me to massage their knee because that's going to help. Again, it's just managing those expectations and perceptions so that they feel that they've been heard, that they actually then trust me enough to come back because, I can only do as much as the person who comes back. If I annoy someone enough with pushing pain science down their throat that they then go to a different practitioner who is just going to rub their knee and good luck, what's more harmful? So it is very much like that balancing act in that regard. And to be open and honest up front, cost. Not everyone can afford to go and see a physio, to go and see an EP, a psychologist, an OT. So there are a number of factors in, I guess, the persistent pain space that do contribute to why it is challenging. So how do we address them individually? Anyone?
How do we individually?
Individually, as individuals, how do we address these challenges? Trick question.
Yes,
So individually, we don't. But to quote the mate John Maxwell, teamwork makes the dream work. So it's interdisciplinary pain care, people. So something that, like, you know, I've always appreciated the difference between inter and multi because I've worked in interdisciplinary clinics. But especially in the literature, it's actually super challenging because the two terms are used so loosely and ambiguously that they'll say multidisciplinary, but then you actually start reading into it and it's from like one particular outpatient clinic in a hospital that they all work together. Hang on, that's actually inter. And so it becomes like the literature isn't super well supported in that regard just because the terms don't get used very well. But what is the difference? At the end of the day, like objectively, very similar. You know, you draw on a team comprising of members from different disciplines, different areas of expertise. I guess multidisciplinary, well, as you're drawing on knowledge from different disciplines who are working like independently within their boundaries. So, you know, say for example, like I said, you know, so like yourself and myself might share a patient. It's multidisciplinary because, like, and even though you know we're both say working on someone's persistent arm pain, just for example, like even if we, I guess the thing there is like interact formally. You know, you might write a letter to myself, I might write a letter back, and it's very fragmented, so to speak, because it's not cohesive, congruent. Yeah. I might not see a patient for a couple of weeks, then I, you know, might see them last thing Friday, so I write the letter early the next week, and then, you know, it's less cohesive. So the difference then, I guess, I've sort of bolded it, but from an interdisciplinary perspective, very similar. It's just that it's really in the same setting, and by interacting, communicating both formally and informally, you've got, and I guess the big component is like having the shared like continuum of like health goals. It's very, we are working together on a particular or a series of goals that we're all aware of and we're all working on together, rather than I'm staying in my lane, you're staying in yours, and we'll talk every so often. I think like the formally and informally bit, I really like, you know, and I guess like our team would probably say, I hate a chat over a coffee, you know, but like just being able to poke your head in next door and say, hey, I saw so-and-so, you've got them in 5 minutes, or you've got them tomorrow, or here's how they're going. A corridor chat over a cuppa, you know, we do, say like our pain roundtables, we have a scheduled meeting where we catch up and we'll talk about, okay, these are some troubles I'm having, these are shared clients, we talk about our pain program. Like, it's very much just more structured and more cohesive because it's in the same setting is the big difference. So, okay, so the International Association for Studies of Pain have a technical definition, which is multimodal treatment provided by a team collaborating in assessment and treatment, as I said, using a shared biopsychosocial model, shared goals. They do actually sort of go on to then nominate that an interdisciplinary team approach is sort of best practice for a group pain program or pain management rehabilitation program. So I guess with that in mind, how effective is interdisciplinary care? I felt very comfortable comparing interdisciplinary pain rehab programs to physiotherapy, given that I am one, so I can sort of like jam on it a little bit. But this particular study, it was, as far as limitation is concerned, it was established, it was comparing 117 patients who had gone through an interdisciplinary pain program to physiotherapy. It wasn't at the same time, so it was sort of they had a population and then they retrospectively compared the two. But as far as by comparing the groups, like it was heterogeneous as far as 3 months of low back pain, you know, ruling out, you know, say mental health factors like mental health illness, and again, there was no sort of difference between the two groups other than the sample size. So what they found is that when comparing like physiotherapy to interdisciplinary team approach, they both significantly improved pain-related disability, physical function, global health, social role satisfaction, anxiety, fatigue, and sleep disturbance. But I guess what they found when comparing them to each other is that an interdisciplinary team had a superiorly significant effect on the pain-related disability, social role satisfaction, fatigue, and sleep disturbance. Now, when I read that, I do not get offended in the slightest, because when you think about these, that's really like they're sort of like the domains that I have less scope in. So, like for example, if someone's sleep is disturbed by anxiety or, fatigue, they're not exercising enough to burn enough energy to feel comfortable sleeping at night, or, those sort of social role satisfaction like OT, it's very much like these sort of 4 factors are the ones that from the interdisciplinary team side of things that the wider team are going to be better at than me. So it makes sense that they would sort of significantly have greater effect by being involved in that team. So to then, I guess, compare MDT to IDT. As I said before, from a research point of view, it is challenging because of just the way that the terminology is sort of thrown about. I'm going to say Gusti because that's how I feel like it would be pronounced. That study, though, admittedly did compare fibromyalgia patient management with MDT to IDT. The other 3 studies there were, I guess, were studies like reviews of literature and like commentary about the difference between the two and its benefits rather than comparison and like analysis. But with keeping all those in mind, what they found was that under a multidisciplinary model, yes, you can really utilize people's individual expertise. You can address specific aspects of pain by referring to a psychologist there, the physio and the OT and whatnot. But again, what they then find is, as we were sort of saying before, is that because everyone is staying in their own lane, it's harder to communicate, it's harder to be cohesive. The management is very vertical, very linear as far as, there's less integration, less cohesion. You don't really know exactly what the other person's up to, so you sort of talk your way this way and then, oh no, actually I didn't know that already. Or again, it's more, I guess, and it can also be more contradictory, which results in a fragmented, disjointed patient experience that has been reported in sort of patient exploratory studies. So as compared to, as we were sort of saying, when with the interdisciplinary model, they very much found enhanced communication, it makes it more cohesive. When you can, as I said, like walk in next door and give a quick verbal handover because they're seeing them straight after you, or you've seen a patient one week, you know that they're going to go and be seeing Chanel, the psychologist, next week. You can, hey, maybe they're not going all that great at the moment. It's really going to be a benefit that you're aware of this in advance, rather than asking, and eliciting, a response because they're aware of it in advance. Again, it leads to greater patient satisfaction, and a big point in the patient satisfaction was that it reduces redundancies of assessment. So instead of using EP and physio, we have this sort of conversation all the time of like, hey Jordan, we noticed that you've already done balance and cardiovascular test and so it's like, hey, that's awesome, I don't have to do it now. So instead of repeating assessments rather than and having access to notes and being able to, even if you get asked by an occupational rehab consultant, hey, what do you think? Well, actually, I can look at Jordan's notes and he observed that the patient can now lift overhead 5 kilos. You can actually include that in some of your commentary back to an occ rehab consultant. Because of the nature of you're all under one roof, you all have access to the same materials. And as I said before, even not having to tell your story 3 or 4 times more often than you have to. There is again a mountain, or there is literature at least, around that. And because again, say, if you've been through, say for example, quite a traumatic mechanism of injury, and if you've been referred to, in say our team, if you've been referred to psychologist, OT, physio, EP, and then you have to tell that traumatic story 4 times, you can actually tell it once, and then these other 3 people can be aware of it. They can maybe check in on things that are particular to their scope of practice, what they need to know, but otherwise you're reducing, again, if we get super technical, like the neurotag associated with telling the story and increasing your pain response, it's not there because of the setting that you're in. So there is a lot of power in that space. So I guess this is starting to talk about, I guess, like the foundations, or I guess like the components of an interdisciplinary pain rehabilitation program. What's actually involved? So to begin with, it's going to be a team assessment of the chronic pain problem or problems, and then their consequences. Again, we're all coming at it from a biopsychosocial space, but naturally we all have our own various, I guess, areas of expertise that we can hone in on a little bit more. It's then going to include, after that, the establishment of a collaborative treatment plan, including interventions by different professions, as I said before, with common goals to be achieved during the period of a program. Communication between team members, the patient, and significant others. So when we say significant others, like, yes, of course, you've got like referral sources, but as far as the person closest to you, there is something like at times like a lot of power in them hearing the same information. Because as we said before, cognitive components, maybe by the time you get home, maybe you've forgotten part of what was taught, or even, because there is, I guess, caring for someone is naturally, it's hard work in its own right, if they are in, say, like, pain-related disability, but sometimes it can actually be counterintuitive if you're looking after someone too much and not letting them do enough to build their capacity. Them actually hearing around, graded exposure and building tolerance and movement can also be sort of really powerful as well. Delivery of different yet synchronized intervention is then again part of the rehabilitative pain program process. Afterwards, you'll educate those interventions and some form of discharge process, including interaction with other stakeholders. So again, as we said, whether that is their GP, their pain specialist, orthopedic surgeon, whoever it is that's involved in their care, we can provide a cohesive communicative process to send that all through as far as like I said, a post-program comprehensive report. Something that I wanted to focus on is the delivery of the intervention. Now, I guess as far as what do we do in a pain rehabilitative program? So dialogue and education, self-training. So put in there like dialogue, because say for example doing it in a group pain program, there is so much power of learning, like experiential learning through other people, listening to their stories, relating to their stories, and maybe feeling validated. Oh, that same thing happens to me, or I hadn't thought about that, and talking about it in a way where you're learning off of your peers rather than me just sitting in the room and lecturing to people, being a discussion rather than a didactic lecture. There's so much more power. And I guess then the self-training component, where we want people to be going away with things that they can work on, things that they can do to train themselves at home. So homework. All right, I want you to go and do a little bit of graded exposure and, go dip your toe in the pool or whatever, because you've said that, that's your goal, that you want to go swimming at the beach. Well, let's start by getting some water on there, working on it from that perspective, giving them something to work on, and then even, or to review a video, review a resource, some sort of material to, I guess, make the learning sticky and reinforce it. Then hopefully they'll remember it, and then once they remember it, they can do something about it rather than going away and being like, oh yeah, that was nice, and never looking at thinking about it ever again. Activity training. So I guess that's, again, very similar to really looking at like that graded exposure and pacing in particular of, looking at an activity, compartmentalizing it, building it up, is very much a part of the program. Meetings, sounds boring, tries not to be, but really, whether it's progress meetings, catching up with someone, how is it that you're going, whether it's a case conference or a meeting with the patient or even up just within the IDT team. You know, again, meetings are very important. You all need to catch up and make sure that everyone's on the same page. I guess the power again of meetings is that, say if I as a physio am delivering a session and a particular participant like says something which is just starting to get a bit of a flag for me, I can go like, hey David, hey Chanel, hey whoever, I noticed this. In your next session, can we just, say Chanel particularly, just again from like the psychology point of view, hey, there was a flag, do you mind investigating that a little bit further for me, and then we can see whether do we need to make any recommendations in that final report, depending on what it was, obviously. I guess with Chanel in mind, psychologically informed therapy is really looking at like your cognitive behavioural therapy, your acceptance and commitment therapy, really important as far as trying to change any of those sort of ingrained beliefs, or at least start to sort of strip them down and give people sort of that choice point, so to speak, of how it is that they're going to engage moving on from or during and or following the program. Relaxation techniques, and again, last but not least for the exercise specialists in the room, but physical exercise is very much like explorative movement, getting someone moving, starting off with, very much like guided, supervised exercises, and over the course of the program trying to promote independence. And that's the biggest thing with the whole program, is you want them to be getting to the end of it with the tools to continue, rather than it finishing and then them sort of going, oh cool, now what? If we haven't gotten to the end of it and they've got like something of a plan of what to do next or something to continue with, we haven't exactly sort of set them up for success. So do the programs actually work? So, we've got a couple, hopefully this doesn't go kick on. Yeah, a couple of studies as far as the benefits of interdisciplinary pain care. The Bujak study was looking at, again, a systematic review and meta-analysis of 221 studies, 3,370 adults who participated in an interdisciplinary pain rehabilitation program. Again, and so that was looking at very much like the specific clinical outcomes, whereas like the LAMPA study was more looking at the interventions that were included and whether they were successful or not. So with that in mind, what they found was that an interdisciplinary pain rehabilitation program allows for that integrated approach that ensures the ease of coordination and communication amongst team members and avoids fragmented care, which is very much what we love to hear. What they then found was that with all of the components that we've already talked about, like what is involved in a program, that is what was found in the LAMPA study, is that those components are most effective. What they then went on to comment on is how they actually benefit sort of like the four like health domains, I guess, being like your health outcomes, the quality of care experienced by patients, healthcare costs, and then the healthcare professional work satisfaction. So in regards to health outcomes, they found that being involved in an interdisciplinary pain rehabilitation program has a significant improvement immediately following the intervention and at 12-month and then 5-year follow-up in comparison to the usual care. All of this was in response to like usual care for pain rather than specifically being the IDT pain program. Pain catastrophizing behaviour, significant, very large effect at completion and then at the 6-month follow-up. Depression, again, significantly decreased. Depression scores, again, also sustained at the 6-month follow-up. Quality of life, significant changes post-intervention, sustained at 6-month follow-up. Opioid prescription, again, no significant improvement in the short term, but significant at 1-year follow-up compared to the control group.
How long was the duration of the intervention?
Does
that mean it's a 1-year intervention?
No, so was, off the top of my head, they did. I'm pretty sure this particular program was a 5-week program. So yeah, so in a
a year after 5 weeks.
Yeah, I can check, but again.
Yeah. So it's not a year-long program.
No. So the studies, as far as the efficacy of the intervention, is that more intensive therapy is more beneficial. So the shorter, because it's essentially you're focusing their attention for a shorter period of time, and rather than if you space it out too much, what happens is, say, okay, you've got to spend so much time rethrashing the same information. I remember 1 week, 2 weeks, however long ago, that we taught you about, bioplasticity. Now we're going to apply it, and you've got to spend so much time rethrashing it, that they found that, the more intensive programs are more beneficial. So as far as purely looking at health outcomes, very helpful. As far as the quality of care experienced by patients, as we said, when looking at it, significantly positive results for their impression of change, interpreted treatment, and it's essentially just suggesting that from self-management, self-efficacy, doing it for yourself, the things that we hope to get out of an interdisciplinary pain program, that there was, again, a significantly positive result for that, which again, if you're being more involved, more proactive in your own healthcare, it's a positive sign for your recovery. As far as the healthcare system costs were concerned, what they found, again, with the same, is that 75% of people involved in the program made a change to their work status. So whether that was going from not working at all to part-time to more hours, part-time to full-time. There was, in 75% of people that participated, there's a change in their work status. And 82% of patients who were labelled as disabled because of their pain, at the time of intake, then again improved their work status. And as far as sick leave is concerned, a significant reduction compared to usual care control groups at 6 and 12 month follow-up for sick leave on its own. Lastly, healthcare professional work satisfaction. Significantly positive job satisfaction from the healthcare professionals that were involved in an IDT as compared to usual pain care. Again, read into that what you will. One, I feel like working in a team of like-minded individuals, it's just better because you all enjoy it. But again, you probably, to be frank, you probably work in that setting because you enjoy it. So again, it's do with the statistic what you will, but at the end of the day, if you have better job satisfaction, working with persistent pain clients, what would you be doing it? So I guess with all of that in mind, I'm going to plug something super quick. We at Thriving Lives Co have developed Thriving Beyond Pain.
Oh, this is your idea.
Yeah, look, it's been mine and David's baby for 18 months, so it's very much like, as far as moving up here, when David and I got talking, it was like, yep, this is what we're doing. And as I said, that's nearly 2 years ago.
Okay.
So, over the last 18 months, give or take, we've been developing our group persistent pain interdisciplinary rehabilitation program. And we're excited to announce that it's up and running and receiving referrals. Thank you. As far as with the program goes, it is using the most up-to-date evidence in pain science, and even as we're sort of saying that, even the way we've set up the program is evidence-based. As we said, it's a 5-week program with 45 hours of content, so patients attending twice a week, they come for 4.5, 5 hours, and we deliver pain neuroscience education, exploratory movement, everything that we have talked about for the last 50 minutes-ish is guiding this program. Again, as far as other benefits, we don't have a wait list. And our intention is that at worst, you'll only, hopefully, ever have to wait until the next program. So we are running the 5-week program every 6 weeks is our intention.
So have you worked out that 5 weeks, 2 days a week for 4 hours is
Effective.
Yeah.
Have I got a deal for you? So we ran a trial. This is is our interdisciplinary pain team. Obviously, a couple of people in the room. But yeah, some of us have met David with his presentations in the past. And then others, we have Lauren, exercise physiologist, who has additional training in functional nutrition for chronic pain. We have Trisha Reeston, who is currently completing a similar sort of certificate through the University of New South Wales. And Chanel is very passionate in the persistent pain space, and her, I guess, niche field has been in the trauma area, which again, as far as trauma and pain goes so closely hand in hand, that she's also is very much like an area of interest for her. But that is our pain thing. But yes, we have done a trial. So we ran this exact program for a trial, and as we sort of rattled off the areas that you are hoping for a persistent pain program to change significantly, this is what we found. So catastrophizing, as far as the average reduction on their outcome measure was a 13, and clinically significant change is 7.73. Score of depression changed by 10 points, clinically significant 4.44. Anxiety 14 compared to 9.98. Stress horrifically close, 9.5 to 9.98. Kinesiophobia, so like a fear of movement, reduced on average by 32% as compared to a clinically significant change of 11%. So as far as all, to be open, honest, and transparent, where the plan is to then do a 3-month follow-up, which is due for next month, which we will be getting
So
back.
when was this follow-up?
This
Is this
was June? No, it's 5 weeks. This was immediately post-intervention.
Okay.
Yeah.
Immediately.
Immediately,
Post
yep.
course?
Yes, so
10
they
5
completed,
weeks?
yep, so they did
Yep.
they did the outcome measures pre-course,
Yeah.
last day of the program,
Good.
outcome measures, and these are the results. And as we said, with intention of following up the participants next month. How are you going? So we will hopefully be able to, whenever someone else maybe does a bad chat, be able to follow up on these for you. But yeah, as I said, that'll be happening then, and it's very much, like, we're super excited. As I said, this has been a pretty long time in the making, and the fact that it's here, we are so stoked that we're actually able to do it. So yeah, I guess otherwise, to summarise just real quick, that's kind of the problem.
Sorry, can I go back to my question?
Go for it.
Which was, so did you try like a 10-week program or a 2-week program?
So
like, how did you come up with 5 weeks?
So
Did
based on the evidence, yeah.
Right.
So evidence suggests, so like the more intensive, and I guess from people, I guess naturally, we could run 5 days a week. It's just not pragmatic, or from a logistics point of
practical
view,
perspective.
to go.
I'm just wondering if that's the
more.
way people remember. Like, have you hit a sweet spot whereby if you feed someone new information twice a week for 4 hours, is that actually the optimal?
So what, from like a feedback point of view, say for example, like too rapidly, like say in the program we had, let's say, 1 week where we got feedback every day on how they felt. So on days where we had longer days, they said it was too exhausting, couldn't concentrate, and they were typically around sort of like 5.5 to 6 hour days. So as compared to, because at the end of the day we are learning. It's very similar to school. You don't go to school for 10 hours.
Yep.
So yes, the feedback was that the longer days and the consecutive days, it was too fatiguing for their concentration ability. So that's where we've set it up to have the sort of 4.5 hours of content twice a week, break it up in between with that sort of Tuesday, Thursday. So it is very much all by design. But yeah.
Do you have any other questions while we're still going?
I can add to that.
You can add to it.
Yeah. So a big part of a big part of pain care is empowering them as much as they can themselves. So that gaps in between the days allows them to actually do the things that we teach them in the program as well. Yeah.
So they get to practice with it.
Sort of experiential learning rather than just listening.
And then every kind of subsequent day is building upon the things that they've learned in earlier sessions and then apply. So they learn how to set goals, and then we're coming back to flare-up management, pacing and things like that, where they're using things they've learned along the program. So, and from education and curriculum in general, we just have an abundance of evidence to suggest that people need enough time to conceptualise it, go over it again, as opposed to just 5 days straight.
But you said that they tend to forget it and you have to repeat it if you string it out too far.
So as far as if
Do you
it's
find,
too
are you building in
spaced.
repetition into those? Or is that-
So as far as like David said, I guess the application component,
Yeah, it's
yes,
repetition.
because it's very much, as I said, like building blocks of, okay, remember this thing we learned last week, now we're going to apply that to this topic, and then it's just, layering foundations, building a house, I guess, rather than just bombarding with information, hoping that it sticks. And that in its own right, that there's a lot of science and adult learning around if it's demonstrated in a way that's metaphor and anecdote and all that, they're more likely to remember it. But there's all the stuff that from a pain science perspective is super important.
So how does that differ between like I know you've just spoken about interdisciplinary.
Yeah, thank you.
I know. But you have some people who you think actually a one-on-one would actually be better.
Yeah. So I guess probably didn't mention it, but yeah, in the perspective of like that intake component of everyone doing their own assessment, that is probably the most important part of the whole process, to be frank, because as you said, some people are cantankerous, some people have trauma history and don't like crowds, or there are certain, I guess, like intake criteria, so to speak, that we're looking at to make sure that like what we propose for the individual is appropriate. Like there will be people that we just go, no, we're going to offer a one-on-one, variation of the program rather than the group program. So that assessment process is going to be like super important. So the way that it'll work is assessment, case conference, to make sure that we thrash it all out.
How do we refer? What's the process? What do you want?
So as far as the funding jurisdictions,
Sure.
we're setting it up.
I know Medicare.
Yeah, so as far as DVA, work cover, like third party CCP, essentially the way that it will work is that we do our assessment, we contact their provider, or again if
So
someone
if I
wants to
write a referral
participate.
letter.
Yep.
All right. You Jordan.
Yep, and the persistent pain program, or thriving beyond pain, we can definitely send through as far as like referral pads, and we can do all that fun stuff.
Yeah, but what do you want to call it? Like, what does work cover call it?
So as far as work cover, we'll call it just like an interdisciplinary pain rehabilitation program. So like the
You reckon they'll have an item number for that?
No, so that's what it's up to
Okay.
then us. So basically you would, for example, as the refer to us for that consideration. We then have to go and do the individual like quotation and approval and all of that. That's from our end. But it's basically like from the referrer's perspective, it's recommend, refer. We then have to go and talk to
So we
customer
recommend an
advisors.
interdisciplinary pain intervention
Yep.
and a work intervention. Yep, that's good.
Very good. Oh, thank you very much, everyone, for listening. I appreciate that a lot. Oh gosh, that's all the references.
Yeah, I was going to say there's a few more than that.
Yeah. Thank you very much, team.